So good morning, everyone. My name is Anders Jeppsson. I'm from Gothenburg in Sweden. So I'm going to talk about antiplatelet therapy after CABG, how we should handle the antiplatelet medications. My background here is that I was a task force member of the perioperative medication guidelines and the patient blood management guidelines. I have these declarations. So there are three issues of antiplatelets in cardiac surgery. It's the question whether or not we should discontinue the antiplatelet drugs before surgery, the role of platelet function testing to guide timing of surgery, and the resumption of antiplatelet therapy after surgery. And all these issues are covered in these three guidelines: the ESC update on dual antiplatelet therapy, the patient blood management guidelines, and also in the perioperative medication guidelines, which were recently published. So let's start with discontinuation of antiplatelet drugs before surgery. In the guidelines, it's recommended that in a patient on acetylsalicylic acid that need to undergo CABG surgery should continue aspirin through the preoperative period. This is a 2A recommendation. It said it should be considered. But as you can see, there's a very low level of evidence C, which is basically expert opinions. The guidelines also state that stopping us at least 5 days before surgery should be considered in patients who refuse blood transfusion, undergo non-coronary cardiac surgery, or at high risk or re-exploration for bleeding. The guidelines also state that stopping aspirin at least 5 days before surgery should be considered in, that was the last slide, I'm sorry about that. These recommendations are based on a meta-analysis in British Journal of Anesthesia published 2015. It consisted of a total of 13 randomized trials and showed a reduced risk of myocardial infarction with an odds ratio of 0.56. There was no significant reduction in mortality, and there was a slightly increased chest output volume, red blood cell transfusion, and re-exploration rate with aspirin. But the author stated also that most of the studies were of low quality. When we come to the P2Y12 inhibitors, they are very different to each other. As you can see here, two of the P2Y12 inhibitors, clopidogrel and prasugrel, are irreversible. That means that you have to wait for the platelet pool to be renewed before you get platelet function back, which takes 7 to 10 days. Ticagrelor is reversible. However, this is more of academic interest because there is no antidote available. They differ also in the onset of effect. You see that clopidogrel takes about 2 to 4 hours, while the new ones works within 30 minutes. And they have also very different duration of the effect, with up to 10 days with clopidogrel and prasugrel and up to 4 days with ticagrelor. However, in the 2014 guidelines, which this slide is from, there was recommended that clopidogrel and ticagrelor both should be stopped 5 days before surgery, which is a bit surprising given the difference in duration of effect. So this is change in the new guidelines, all three guidelines, where it's now recommended that you should postpone surgery for at least 3 days after discontinuation of ticagrelor, or 5 days after clopidogrel, and 7 days after prasugrel. And you can see that this is a 2A recommendation, it's a should recommendation at the level B. And this is mainly based on this study, which we performed in our institution, where we investigated the coronary artery bypass grafted related bleeding complications in patients treated either with ticagrelor or clopidogrel. We included over 2,000 patients, and in the clopidogrel group, there was a continuous decrease in the risk of bleeding complication if you postponed surgery. It was less bleeding complications if you waited 72 to 120 hours, and even less if you waited more than 120 hours. This was in contrast to the results in the ticagrelor group, where you first can see that the incidence is very high if you don't, of bleeding complications is very high if you don't stop it, or if you stop it less than 3 days before surgery. But there were no difference between 72 to 120 hours, that is 3 to 4 days, or more than 120 hours, that's 5 days or more. This study was also supported by 2 smaller studies, one from Netherlands showing no difference between aspirin-treated patient and ticagrelor-treated patient if the treatment was stopped more than 72 hours after surgery, and the same results from another prospective observational study. So we're now recommending to stop ticagrelor 3 days before surgery, not 5 days anymore. The next issue I want to cover is the role of platelet function testing to guide timing of surgery. In the guidelines, it's now stated that platelet function testing may be considered, it's a 2B recommendation, to guide the decision of the timing of cardiac surgery in patients who have recently received P2Y12 inhibitors. The rationale for using platelet function testing at all in patients is that is a large intra-individual response to platelet inhibitors. We have a large proportion of non or poor responders to clopidogrel. The recent studies suggest that it can be up to 30%. And we have also patients with aspirin resistance. So that's one rationale for testing platelet function. Another is that the preoperative platelet function measured with these devices predicts perioperative bleeding complications. This is one method to measure platelet function. It's called impedance aggregometry. The device is called multiplate, where you can get an aggregation curve, and the area under the curve is then a measure of platelet function. You cannot measure platelet function with thromboelastometry or thromboelastography in patients on pharmaceutical platelet inhibition. This is from another study that we have done, where we followed patients that discontinued ticagrelor before surgery. And as you can see, it's a nice, smooth curve with increasing platelet aggregability for each day the drug has been discontinued. However, this looks very nice, but when you look at the individual patient, it looks like this, which is quite different. So there is a large variation in the platelet inhibition effect of the drugs. This is also illustrated in another study where we measured platelet function and related the aggregation capacity with the time since last dose. And you can see that there are patients that have poor platelet function also 100 hours after the drug has been discontinued. On the other hand, we have patients who have recovered their function within 24 hours. So these patients could have been able to operate much earlier. And in these patients, you might have to wait a little longer. And when we plot the aggregation capacity with the probability of severe bleeding, you can see there's a rather steep curve with the highest bleeding risk in patients with poor platelet function. And an ADP value of 10 is what you normally have if you don't stop the treatment at all before surgery. And you can see the risk for bleeding is up approximately 60%. This is another study in randomized controlled trial studies where they could show that shorter waiting times when platelet function testing was applied in clopidogrel-treated patients. So the final issue I want to discuss is the resumption of antiplatelet drugs after surgery. When it comes to acetylsalicylic acid or aspirin, it's recommended to restart aspirin as soon as there is no concern over bleeding, but within 24 hours of CABG. And this is a 1B recommendation, so it's a pretty strong recommendation. And also in patients that have another indication for aspirin than coronary artery disease, it's recommended that you should restart it as soon as possible after surgery, within 24 hours. This is based on a number of observational studies. This is the largest one, published as early as 2002 in over 5,000 patients, where actually all ischemic outcomes were better if the patients received aspirin early after. You can see that is both from death from all cause, myocardial infarction, stroke, etc. And in that study was also the use of aspirin associated with a lower 30-day mortality, also after adjustment for other factors influencing mortality. When it comes to resumption of P2Y12 inhibitors, it's recommended that in patients with a recent coronary stent implantation who subsequently undergo cardiac surgery, it's recommended to resume the P2Y12 inhibitor postoperatively as soon as there is no concern over bleeding, but not longer than 48 hours. And then you should continue the treatment as long as the recommended duration of the therapy lasts. It's a 1C recommendation. Again, a very strong recommendation to do that, but with very poor evidence. It's also written that in patients longer after coronary stent implantation or any patients with acute coronary syndrome, you should resume the P2Y12 inhibitor postoperatively and continue until the recommended duration. Again, a 1C recommendation. These recommendations are based on pretty weak evidence. There's mainly sub-studies of ACS populations which contains both surgical and non-surgical patients. And there's also some meta-analysis of retrospective observational studies and small randomized trials with surrogate endpoints. This is probably also the reason why there is adherence to these recommendations that has been reported are very poor. You can, of course, ask why this is so poor. Is it a lack of hard evidence for this treatment, the resumption of P2Y12 inhibitors after surgery, or is it a fear of bleeding complications, or a combination of both? This is data from the Sweetheart Registry, where we investigated how large proportion of the patients that actually received dual antiplatelet therapy after CABG in ACS patients, and only 25% of the patients received the recommended treatment. That's the reason why we're now starting the TAXI trial. This is an investigator-initiated randomized interventional international study comparing dual antiplatelet therapy with ticagrelor and acetylsalicylic acid with standard of care, which is, as you saw in the latest slide, aspirin only. We will include 2,200 patients. The patients will be randomized, treated for 12 months, and then we'll follow it up in national registries. And the primary efficacy endpoint is MACE, combination of death, myocardial infarction, stroke, and new revascularization. And the primary safety endpoint is major bleeding. It's expected to start in the first quarter of 2018. So, ladies and gentlemen, my take-home message from this presentation is that you should continue acetylsalicylic acid during the perioperative period if there's no contraindications for that. You should stop the P2Y12 inhibitor before surgery whenever possible, and you should stop ticagrelor at least 3 days, clopidogrel at least 5 days, and prasugrel at least 7 days before surgery. You should consider using platelet function test to guide timing of surgery in patients with ongoing or recently stopped dual antiplatelet therapy. And you should restart the P2Y12 inhibitor in all patients with acute coronary syndrome, not in patients with stable angina. Thank you very much.